The slide is not moving. Excuse me. Okay, here we are. Okay, so these are the primary causes of chronic liver disease. Now, the chronic liver disease, we mean to say that there is chronic insult to the liver as a result of these reasons, which is hepatitis B, C, alcohol, unknown, and certain other causes, along with malignancies. So these are the causes of chronic liver disease. You must be aware of them. So what we are going to learn today is this: how this chronic liver disease progresses, what are the complications, how you diagnose these complications, and a bit of overview that how you are going to treat these complications as a result of chronic liver disease. So normally the liver, it progresses to fatty liver in cases of obesity, and then there is liver fibrosis. Now I want all of you to stop over here and understand this concept, because this concept is the key to understanding the complications of cirrhosis. Normally, when any organ in the body is injured, the normal tissue is replaced by the normal tissue. But in certain organs, the replacement is not by the normal tissue, but it is by replacement with fibrous tissue or the scar tissue, like heart, like brain. And so is the case with the liver as well. And a result of repeated injuries, as a result of repeated insults to the liver, and this healing process which happens in the liver, there is repeated fibrosis in the liver. And this repeated fibrosis over a long period of time, which can be in decades, progresses to cirrhosis. So cirrhosis is basically a histopathologic, is a radiological term. So you have to understand that. Now, what happens to the liver as a result of that cirrhosis, and why these complications happen, the coming slides they are going to explain you well. Now, this is a pathophysiology of cirrhosis in cases of chronic hepatitis C. It is a very busy slide, but what all you need to understand, that there is cascade of events which are happening result in fibrosis. So this is the normal liver cell on your left side, and then mildly diseased liver cell. And then what you see in moderately diseased liver cell, you see that the architecture is getting distorted from the smooth liver parenchyma to a cobblestone appearance, a nodular appearance, and then severely diseased liver cell leading to cirrhosis. I'll take the questions in the middle. I'll tell you that when you can ask me the questions, I'll finish a topic, then I'll ask you. So don't worry about the questions. So it usually takes around 2.5 decades for a normal liver to become a cirrhotic liver. So once a patient develops cirrhosis, it's not something which happens just over a night or over a day. It takes years and years of injuries. So what are the complications of cirrhosis? Now, these are the usual complications. So complications of cirrhosis can be broadly divided as a result of two: portal hypertension A, B is liver insufficiency. As a result of portal hypertension, these certain complications happen which are variceal hemorrhage, ascites, encephalopathy. Then there is liver insufficiency. What do we mean by liver insufficiency? We mean that there is increased toxic metabolites in the liver, and there is decreased synthesis of certain important factors in the body as a result of malfunction of liver, and increase in the toxic metabolites in the blood as a result of liver insufficiency, which leads to encephalopathy and jaundice. How this happens, the next slide is going to tell you. Now, what you can see the liver, and then the portal vein which is entering the liver. Now, the portal vein is formed by combination of the splenic vein, which is the blue structure which is coming from the spleen, and then the superior mesenteric vein which is coming from the down. And then they both behind the head of the pancreas. Now, the pancreas in actual is in front of these structure, but for the sake of description, I have carried this cartoon which tells you that how the portal vein forms. Now, usually the blood flows from the spleen, from the superior mesenteric vein, carrying the nutrients, carrying the toxic metabolites, and then they go to the liver for the synthesis, detoxification of these substances. Clear? Now, what happens as a result of repeated liver injury, if you recall the slide in which you saw the cirrhotic liver, in which the liver has got a nodular surface, the sinusoids in the liver, they get distorted. As a result of which, there is increased resistance to the blood flow going from the portal vein to the hepatic veins. Now, when there is increased resistance to the flow, the blood, instead of flowing from the liver through the liver to the heart and then going upwards, it backflows. And when it backflows, it results in splenomegaly and opening of the portal and systemic channels. Now, this is a very important concept which you need to understand. If somebody has opened the cameras, I would ask to please close their cameras. It's a request. Okay, Ji. Now, another diagram which tells you the same thing, but in addition to that, this diagram tells you that what are the areas where the portal circulation it meets with the systemic circulation. First is the esophageal and gastric varices, then the gastrosplenic veins, then you have got retroperitoneal collaterals, you have got the hemorrhoidal veins and the hemorrhoids, you have got the umbilical veins. So these are the sites where the portal circulation it meets with the systemic circulation, and these are the sites where, because of the backflow of the portal blood, there is increased pressure in these areas, and these areas are particularly vulnerable to bleed. Importantly is the esophageal varices, the gastric varices, and the rectal varices. And this is an example of that. On the left side, you can see this is the esophagus, which with the esophageal varices along with a red veil sign and a cherry red spot, and then you can see caput medusae around the umbilicus. So these are the areas where the systemic circulation it meets with the portal circulation. Okay, so as a result of these complications, the first thing happens is the ascites. This is the major topic for today. It is the most complication of cirrhosis. 60% of the patients with compensated cirrhosis, they develop ascites within 10 years during the course of their disease. Ascites only occurs when the portal hypertension has developed and is primarily related to an inability to excrete an adequate amount of sodium into urine, leading to a positive sodium balance. So a large body of evidence suggests that the renal sodium retention in patient with cirrhosis is secondary to arterial splanchnic vasodilation. Remember that there is increased nitric oxide production in cases of CLD. As a result of that, it is a state of relative vasodilation. So हम अभी उसकी बात करते हैं कि उससे क्या मसला होता है, relative vasodilation है तो वो क्या करता है. So this causes a decrease in effective arterial blood volume with activation of arterial and cardiopulmonary volume receptors and hemostatic activation of vasoconstrictor and sodium retaining systems. Renal sodium retention leads to expansion of extracellular fluid volume and formation of ascites and edema. So what happens as a result of increased production of nitric oxide, there is a state of vasodilation. Now, as a result of vasodilation, there is the signal goes to the kidney that there is decreased blood volume. However, there is an excess of the plasma volume, and as a result of which, to counter-regulate that, to counter-answer that, the kidneys they go in a state of partial vasoconstriction, and that is the problem. That is the root of the problem. So the development of ascites is associated with a poor prognosis and impaired quality of life in patients with cirrhosis. Thus, patients with ascites should generally be considered for the referral of liver transplantation. Approximately 75% of the patients presenting in ascites in Western Europe or USA have cirrhosis as the underlying cause. Now remember, over there, the major cause of CLD was alcohol. Now it is globally it is turning towards obesity and NASH-related cirrhosis. So can we grade the ascites? Yes, we can grade the ascites. And this is the grading of the ascites: grade 1, grade 2, and grade 3 ascites. This is adopted from the International Ascites Club. Grade 1 ascites mean that there is only mild ascites, which is only detectable by ultrasound. For that, no treatment is required. Actually, there is no papers, randomized control trial on that, how to treat that. The grade 2 ascites is moderate ascites, in which we go for restriction of sodium intake and diuretics, and larger ascites, in which we, in addition to sodium restriction and diuretics, we go for large volume paracentesis. So this is how we treat the ascites. So a diagnostic paracentesis with an appropriate ascitic fluid analysis is essential in all patients investigated for ascites prior to any therapy, to exclude causes of ascites other than cirrhosis and rule out spontaneous bacterial peritonitis and ascites. So new onset ascites should be tapped. When the diagnosis of cirrhosis is not clinically evident, ascites due to portal hypertension can be readily differentiated from ascites due to other causes by serum to ascites albumin gradient, which is called the SAAG ratio. If the SAAG is greater than or equal to 1.1, ascites is ascribed to portal hypertension with an approximate 97% accuracy. Now, usually we do not come across this situation usually, but there are cases in which the ascites is new onset, or there is lack of support from the radiological guys and from other assays, and we are unable to differentiate that whether this ascites is because of CLD or any other cause. On top of that, to complicate the whole situation, there are conditions in which patients can develop tuberculosis or malignancies on top of cirrhosis, and then we have to differentiate that this ascites is because of CLD, or it is because of tuberculosis or any other malignancy. For that, we usually get help from the SAAG ratio. So this is, you order the albumin in the ascites, you order the albumin in the serum, and then you minus the two. If the answer is more than 1.1, it is usually because of portal hypertension. Now, the catch over here is this, that the answer is if you have got an SAAG of 1.1, more than 1.1, it is because of portal hypertension, and portal hypertension is not equivalent to CLD. There are other causes of portal hypertension which we are going to just visit. So serum to ascites albumin gradient is more useful than the total protein concentration of ascites in the classification of ascites. This gradient is physiologically based on oncotic hydrostatic balance and is related directly to portal pressure. The serum to ascites albumin gradient is calculated by subtracting the albumin concentration of ascitic fluid from the albumin concentration of serum obtained on the same day. So SAAG ratio is serum albumin minus the serum albumin of the ascites, and the patients with a gradient of 1.1 or greater have portal hypertension, whereas patients with gradient less than 1.1 do not have portal hypertension. Okay, this is another very important diagram. This is very important diagram which one need to understand, that if you have got a SAAG ratio of more than 1.1, it means that there is portal hypertension. Now, the second thing which you have to see is the ascitic protein content. If the protein content is less than 2.5 grams, usually it is cirrhosis, but Chiari syndrome, which is late, massive liver metastasis. However, if the ascitic protein content is more than 2.5, it is because of congestive heart failure, early bud Chiari syndrome, IVC obstruction, sinusoidal obstruction syndrome. And if the SAAG ratio is less than 1.1, it means that the portal hypertension is not involved in the development of ascites, and the causes are biliary leaf, nephrotic syndrome, pancreatitis, peritoneal carcinomatosis, and tuberculosis. So this diagram is something which is very important, and one need to understand this. Again, same depiction in a separate setting. Now, on the left side, you can see that the protein content of less than 2.5 and more than 2.5. If the SAAG is more than 1.1, then cirrhosis, non-cirrhotic portal hypertension. If the SAAG is less than 1.1, nephrotic syndrome. Now, so you have got, this is very important entity which one needs to understand, in which the SAAG is less than 1.1 and the protein content is less than 2.5, and this is the case with nephrotic syndrome. If you have got a SAAG of less than 1.1, the protein content more than 2.5, then carcinomatosis, tuberculosis, cirrhosis, and pancreatitis. So this is something which we need to understand. Okay. So this we have already done. Our diagnostic paracentesis should be performed in our patients with new onset ascites, grade 2 or grade 3, and patients hospitalized for worsening of ascites or any complications of cirrhosis. This is a repetition of what we have learned. Most common complication of decompensation in cirrhosis is ascites. It develops in around 5 to 10% of patients with compensated cirrhosis per year. Significant impact on patient's life as far as impairs the patient's working, social life, frequently leads to hospitalization, requires chronic treatment, direct cause of further complication, and then there is a poor prognosis. 5-year survival rate is 30%. Now, how you understand the survival rate? Very important. It means that if a patient has developed cirrhosis as of today, that is 10th of July 2020, if 100 patients have developed ascites as of today, 30 of them, they will not live beyond 3 years. So this is how you read the survival. Ascites can be uncomplicated or refractory. So ascites is uncomplicated when it is not infected, and it is refractory or associated with impairment of renal function. Let's skip this slide. Okay. So uncomplicated ascites, the management, grade 1 or mild ascites, no data on evolution, and not known if the treatment modifies the natural history. Grade 2 moderate ascites. Now remember, as far as the ascites is concerned, we tell the patients two things. A, do not take salt. Do not take salt. And when we say salt, it means no salt diet, because the natural ingredients contains the amount of the sodium which is required for one to continue on. And then we give two diuretics, and you can remember the name, which is aldactone and Lasix, in a combination of 50 to 20. For every 50 milligrams of aldactone, we give 20 milligrams of Lasix. Now, this is the rule of thumb. So if you remember these two things, that is no salt diet for life, A. Then diuretics, which is 50 milligrams of aldactone and 20 milligrams of Lasix, that is going to suffice you as far as the treatment of ascites is concerned. For grade 3 or large ascites, we go for large volume paracentesis under a strict sterile condition. It is the treatment of choice, and ascites should be completely removed in a single session. Now, this comes with a this statement can be taken with a pinch of salt, because at times the large volume paracentesis is complicated by sudden onset of hypertension. So we usually check for hypertension after tapping every 5 liters, and if the blood pressure allows, then we can tap the total ascites. Otherwise, it is usually divided into different sessions. But when we do the LVP, it should be followed with plasma volume expansion, and the plasma volume expansion should be performed by albumin infusion. Now, theoretically, it is 8 grams of albumin for every liter of vessel. If you are planning to remove 5 liters, you should give 40 grams of albumin, which is pretty expensive. So for over 5 liters of ascites is more effective than other plasma expanders. For less than 5 liters of ascites, treat with sodium albumin due to concerns about the use of alternative plasma expanders. After LVP, patients should receive the minimum dose of diuretics necessary to prevent reaccumulation of ascites. When needed, LVP should be performed in patients with AKI or SVP. So I'll take the questions over here. If you have got any questions, we can take the questions regarding the ascites now. Okay, no questions. So I'm moving forward. Hepatorenal syndrome. बेटा ये मुझे चार्ट से आ रहा है. Okay, if liver can't recover after injury, then how liver grows after one transplant? Okay, this is a question from sir. What is LVP? Okay, uh, just three questions. Okay, LVP means large volume paracentesis. So ये तो हो गया. दूसरा, if liver can't recover after injury, then how liver grows after one lobe transplant? ये वो रिकवरी की बात नहीं हो रही है. यहाँ पर बात ये हो रही है, ये रिकवर वो रिकवरी नहीं है. ये है कांस्टेंट माइक्रोस्कोपिक इंजरी जो होती है. इसके केस में नॉर्मल पेरेन्काइमा रिकवर करता है विद द फाइब्रस टिश्यू फॉर्मेशन. वो रिकवरी और है, वो रिसेक्शन वाली रिकवरी और है, ये वाली रिकवरी और है. वो रिकवरी ट्रांसैक्शन वाली है, वो और मामला है. दिस इज समथिंग एल्स. आई होप दैट आंसर्स. ओके जी, हेपेटोरेनल सिंड्रोम. So this is how hepatorenal syndrome happens. Advanced liver cirrhosis, you can concentrate on the left side of the panel, develops the portal hypertension. We have said it is a vasodilatory state. As a result of which, you can see that there is, sorry, splenic arterial vasodilation. As a result of which, decrease vascular resistance, and then there is effective arterial hypovolemia. As a result of which there is a false sense, as a result of which there is renal vasoconstriction. जब renal vasoconstriction हो जाएगी, there would be GFR, decreased GFR, and that, as a result of that, there is falsely increased injuries, renal injuries. So now these kidneys are fine. If you take a patient with hepatorenal syndrome and you take out their kidneys and you transplant in a person with CKD, the chronic kidney disease patient, the kidneys are going to just work fine because the kidneys are not abnormal. The problem is with this arterial vasodilation and renal vasoconstriction, and that is because of cirrhosis. So this is the common understanding. This is the backbone of hepatorenal syndrome. Hepatic encephalopathy. Hepatic encephalopathy is defined as a spectrum of neuropsychiatric abnormalities in patients with liver dysfunction after exclusion of brain disease. So this is a very important definition. So it is a reversible neuropsychiatric illness. Always remember, it is a neuropsychiatric illness and it is irreversible. After exclusion of the brain disease, hepatic encephalopathy is characterized by personality changes, intellectual impairment, and a depressed level of consciousness. Now, what is the pathogenesis? The pathogenesis is there is increased ammonia formation by the protein broke down in the GIT. Now, as a result of liver dysfunction, this ammonia, it does not get detoxified and it passes through the blood-brain barrier, and then it causes hepatic encephalopathy. Now, there are multiple chemical pathogens which has been involved and explained for the development of hepatic NCAF, and that includes increased sensitivity to glutamine and GABA, increased circulatory levels of endogenous benzodiazepines, but ammonia is the thing which, along with the GABA, which plays the pivotal role. Now, you can understand on the left side of the diagram, there is toxic nitrogen compounds, and a result of which decreased synthesis power of the liver. These they goes undetoxified, and then they crosses the blood-brain barrier, and that they have got the toxic effects on the brain. Then there are other endotoxins along with the ammonia, which includes ammonia, mercaptans, phenols, free fatty acids, GABA. So these are certain endotoxins which leads to development of hepatic NCAF. But along with this, there are certain precipitating factors which can precipitate hepatic NCAF, and these include anything which increases the nitrogen load. For example, constipation, gastrointestinal bleeding, excess dietary intake of protein and fatty foods, but that statement should be taken with caution because the patient needs around 0.5 to 1 milligram, 0.5 to 1 gram of protein per kg of the body weight. अब यूजुअली हमारे यहाँ होता क्या है कि वो पेशेंट का प्रोटीन कंटेंट जो खाना है और खासतौर पे जो मीट होता है बिल्कुल बंद करवा देते हैं, और दैट potentiates the problem. And then there is azotemia, and these things potentiates or precipitates the hepatic encaphalopathy. Along with that, other are infections, trauma, electrolyte and metabolic imbalances, hypokalemia, alkalosis, hypoxia, hyponatremia. So anything, literally anything from drugs to GI bleed to renal failure to electrolyte imbalance to this and that, when the liver is not functioning normally, as a result of which the patient can go in a state of hepatic encaphalopathy. Let me see, I've got a few questions over here. Sir, how does GI bleeding and constipation leads to increased nitrogen load? Okay, GI bleeding, as a result of bleed, there is catabolism of blood, and as a result of that along with constipation, there is increased production of ammonia in the intestine. Now, what happens that this ammonia usually is excreted in the form of the stools. And I'm answering this question by Priyanka, that as a result of constipation, there is increased production of ammonia. There is not increased production, there is production of ammonia in every human being. Now, usually that ammonia goes out in feces. Now, when that there is constipation and that complemented or augmented by cirrhosis, this ammonia concentration, which usually does not causes any pathology in a normal human being, it causes hepatic encaphalopathy in a patient with cirrhosis. Hope that answers the question. Okay, so clinical features of hepatic encaphalopathy: disturbances in consciousness, disturbance in the sleep rhythm, impaired memory, एप्रेक्सिया. व्हाट इज द मीनिंग ऑफ एप्रेक्सिया? देखिए, हम इस तरह से डायग्राम बनाने को कहते हैं पेशेंट को कि ये स्टार बना के दिखाओ, तो पेशेंट ऐसा बना के दिखाता है, या हम कहते हैं घड़ी बना के दिखाओ, तो ये उल्टी पुल्टी घड़ी बना देता है बेचारा. देन देयर इज कंफ्यूजन, एपैथी, ड्राउजीनेस, सोमनोलेंस एंड कोमा. यूजुअली जो पेशेंट्स हमारे पास आते हैं, जो हमारे पास जो कंप्लेन होती है वो इस तरह से होती है कि एक तो जो डे नाइट पैटर्न होता है स्लीप का, वो खराब हो जाता है. पेशेंट के घर वाले आके कहते हैं रात भर जागते रहते हैं, दिन भर सोते रहते हैं. दूसरा ये होता है कि घर वाले कहते हैं कुछ अजीब अजीब सी बातें करने लगते हैं, एक बात बार बार दोहराने लगते हैं. ये यूजुअली होता है. देन यू हैव टू कैच, बिकॉज हेपेटिक एनकेफ की लॉन्ग टर्म बहुत सारे इफेक्ट्स हो सकते हैं. Childish behavior, may be aggressive, outburst, euphoric, and fetal hepaticus. Now, foul smelling breath associated with liver disease due to mercaptans. मैंने आज तक ये मुझे सूंघी नहीं है, मुझे समझ में नहीं आती है fetal hepaticus कौन सी होती है, मैंने नहीं सूंघी आज तक. But anyways, now neurological signs, there is a flapping tremor. We ask the patient to extend their arms, and their hands should be their hands should be extended at the wrist, and we ask the patient to hold their hand in that position, but the patient is usually unable to do so. और उसके साथ क्या होता है, फ्लैप हो रहा होता है, बार बार हाथ आगे पीछे आ रहा होता है. Then exaggerated tendon reflexes हो रहे होते हैं. And last but not the least, it is the extensor plantar response, which you can see that you scratch a key on the sole of the patient, the toe is going to go upwards rather than downwards. I'll take the questions in the end. So basically, these are four grades of hepatic encaphalopathy. Grade A is poor concentration, slurred speech, slow mentation, distorted sleep pattern. Grade 2 is drowsy but easily arousable. Grade 3 is usually aggressive behavior, gross deterioration. Grade 4 is unresponsive or comatose state. So हमारे पास usually when the patient comes to us, who is a old patient to us, usually grade 1 हम उसको admit नहीं करते हैं. But grade 2, grade 3 we usually admit the patient. Grade 1 पे हम कोशिश करते हैं उसे घर पे manage करने. And this can be the stage when the patient seems a bit confused over here. In stage 2, you can see the patient is drowsy. Stage 3 usually is patient very, but not the least, the patient is comatose in case of stage 4. Usually it is a clinical diagnosis. Always remember, it is a clinical diagnosis. It is not a lab diagnosis. Hepatic encaphalopathy is a clinical diagnosis, but routine investigations should be carried out like CBC, LFTs, electrolytes, urea, creatinine, prothrombin time, albumin. The reason being that, as I have already told you, that as a result of any minor problems in these states like electrolyte imbalance or azotemia, the patient can go in hepatic encephalopathy. Elevation of blood ammonia, it is only for the lab purposes. I never ordered liver elevation of, I never ordered blood ammonia, and I never do so. EEG usually reserved for complicated cases. CSF and CT scan, they should be normal. However, remember, the patient with hepatic encephalopathy, they usually wake up within a day or so. If they do not wake up, and then we are getting inquisitive that whether hepatic encephalopathy is the reason, then we go for CT scan or the CSF analysis. Usually we don't order this sort of test. But we should be very much cautious about the differential diagnosis, includes subdural hematoma. They have got a tendency to bleed, drug or alcohol intoxication, Wernicke's encephalopathy, and hypoglycemia. Management is supportive treatment. Specific treatment aims at decrease the ammonia production in the colon, elimination or treatment of precipitating factors, and this is the primary drug which you use is the lactulose. It is a non-absorbable disaccharide. It produces osmosis of water and diarrhea. It reduces the pH of colonic content and thereby prevents the absorption of ammonia. And most importantly, it converts ammonia into ammoniamine. Now, ammonia which is NH3. It does not have a positive ion on itself, but ammonium has a positive ion. As a result of which, it loses the capacity to crosses the intestinal barrier. So it remains in the gut and then is excreted out. So that's how the lactose takes care of the business. Thank you. I can take your questions now.
जी डॉक्टर तैयब क्या एंड करें या क्वेश्चन आंसर करेंगे?
जी क्वेश्चन अगर कोई है तो उनसे बात करा दें।
हाँ वो नहीं, आप देखिए मोर के ऑप्शन में जाए, वहाँ पर चैटिंग का ऑप्शन होगा, वो ऑन कर लें। वो आपके पास जो भी है।
अच्छा ओके सर, कैन यू एक्सप्लेन अगेन रिलेशन ऑफ मीट इंजेक्शन टू हेपेटिक एंकेफ? मीट इंजेक्शन किस तरह से होता है? शाजीन आई एम सॉरी बेटा, मैं नाम सही नहीं पढ़ पा रहा। इस तरह से होता है कि अगर मीट बहुत ज़्यादा ले ले पेशेंट तो भी हेपेटिक एंकेफ का डर होता है, बट यूजुअली इतना मीट लेते नहीं है। सर ये सिम्टम्स तो सब हॉस्टलाइट्स में होते हैं। कौन से सिम्टम्स भाई? सर कैन यू रिपीट SAAG? Sure, I can repeat SAAG. SAAG is you take the albumin content in the ascitic fluid, and then you take the albumin content in the serum and you minus the two. If the answer is more than 1.1, it is total hypertension. The ascites is because of total hypertension. Any other questions? So I thank you everyone, and hope you learned this thing. And if there are any questions, you can please ask me whenever you come back. Please take care of yourself and be safe. Assalamu alaikum wa rahmatullahi wa barakatuh.